All right, test, test, test. Can y'all hear me? There it goes. All right, I think we're about at 1 o'clock, and Bill had to be at another important presentation, so I guess I introduced myself. I'm Dr. Michelle Stowe, the medical director here at the Pines. I think I know most of you all by now. And I'm sorry the topic, some people didn't get the topic ahead of time. Today it's going to be on urinary incontinence and hormones as we age, which is a huge topic, and I'll do my best with it. And just to let you know, at the end of the presentation, before we do questions and answers, you'll see again the topics coming up over the next few months. And I'll ask Ariel to put those on the agenda so you all can see which ones you want to attend or maybe which ones you have no interest in. So again, I'm Dr. Michelle Stowe. I was going to speak, as we've done before, for about a half hour, 35 minutes, and then do a lot with questions and answers, because this is kind of a big topic. And I'm curious what you all want to know about or don't know about. I will say that I'm an internist and a geriatrician. I am not a urologist. And part of the presentation is going to be exactly what I just said. Why are we talking about that? Why am I talking about that? And when to go to urologist or what their job is. Okay? Can you all hear me all right? All right. Here we go. This is a harder topic for me, so I'll try and go slow and we'll see how this goes. Oh. Okay. So this is going to be the outline for today. I'm going to talk a little bit about urology and hormones and why in geriatrics and why we are talking about this, specifically me. Number two, we'll talk a little bit about urinary incontinence, both male and female. And it'll be a little heavier. I'll have more information for the ladies. So I apologize to the men, but again, I'll get to why that is. We'll move on a little bit to urinary tract infections, and then hormones and sexual health. And most of y'all are past menopause, ladies, but still a little bit more about menopause and our hormones as we get older. Sound okay? All right, so first of all, why am I talking about this? Well, right away when I started at the Pines, there were a lot of questions. Help us. We need more information on, especially women, on urinary incontinence. Seems to be a field a little bit like dementia, that it's so common and yet we don't talk about it enough. It's almost like a stigma. If you have problems holding your urine, it's embarrassing, obviously, and we don't have a simple cure. But I think one of the main problems has been we have not had female urologists. It's only 20% of urologists are women. Remember, urologists are those that study the bladder. I'll get in a little more detail, but in fact, in the 1980s, Dr. Lockridge will appreciate that, we had 22 female urologists in the USA. So last I checked, we all have bladders, not just men. We all have kidneys, we all have ureters, we all have incontinence issues. So it's been an ongoing issue, females going into urology. And why is this important? Well, male health, obviously male urologists deal a lot with the prostate. But if it's 90% of the urologists are male and you study the prostate, what happens to the women's health with bladder and incontinence? And so over the past 20 years, this has been a big push. Mentors I put up there as I was going through medical school, I was very interested in urology. And I was told women don't go into that. And in my day, I kind of walked off, okay, I guess I won't go into it. You know, now women do, proud to say that, but still I didn't have any leaders to look to at the time. Mentors. So what is the field of urology? Kidney stones, erectile dysfunction, that'll be more male, overactive bladder, urine infections, bladder cancers. The list is very long, but most of this applies to male and female, obviously. And then finally, hormones, huge topic, but how is that involved with urology? Hormones are very involved with urology. The hormones greatly affect the bladder, the ureter, and all those parts down there. So that's why I think it's an interesting topic to talk about. Finally, if there's not a lot of female urologists, well, who does deal with, for instance, if you want to go see a doctor for your incontinence, OBGYNs, right? Gynecologists should deal with this. Some of them do, and some of them don't really want to. What about your internist or your primary care? Some of them talk about it, some of them don't want to. So especially for women, it's almost this field that got left out. Well, who's going to deal with incontinence and hormones, especially in women as we age? Geriatricians have picked up a little bit of the slack, but as I've already talked about, we don't have enough people going into geriatrics. So it's this little bit of a field that's left over there in the corner of who do you go to if you have a problem. Okay, just to go over a little bit about what we're talking about. This is a picture of the bladder. Men and women have the same bladder. We have, openings that lead to the tube, the urethra that leads out. I'm making this very simplified, by the way, for the medical in the audience, so sorry about that. We're going to start talking a little bit about incontinence as one of the topics. In general, incontinence is a loss of control. We're going to talk about urine, not stool, not EM today. With urine incontinence, we like to divide it into two types, urge and stress. So urge is, y'all probably remember the commercials, when you gotta go, right? So suddenly you get that urge, I gotta go to the bathroom, and oftentimes you don't make it there in time. You may have to wear a little bit of pull-up or a pad, and you may just, the thought of having to go to the bathroom trigger you to have to go. So that's urge incontinence. It's the more common. It's the one most of us need to talk about as we get older. The other kind is called stress incontinence. That's when you cough or you sneeze and you lose a little bit of urine. That's actually a different type of incontinence and is a different type of treatment. It's actually harder to treat. A lot of times people ask about, should I be tested for which kind? And urologists tend to love to do tests to find out which kind, but really it's pretty basic on figuring out which type you have. And some people have a mix of both. Treatments, we'll go through a little bit about treatments. The cost of society. Imagine just simple things like pull-ups and diapers and pads and how much we're spending on incontinence. So we really do need more information out there and better treatment. And then finally, I'll touch a little bit about some of our new concepts on how to treat incontinence. All right. So let's start with what your incontinence, we just talked about what it is. Those are the kidneys. They lead down to the bladder and then out your urethra. So here's to represent the males. This is the men. That little bulge at the end is the prostate. So male and female incontinence is obviously very different in some ways. Prostate, women do not have a prostate, so we won't have the problems with an enlarged prostate or prostate causing bladder issues. As far as prevention, prevention with incontinence should actually go way, way, way back, especially for women. Most of us are at risk if any of us had kids or pregnancies, right? So pregnancy, that extra weight, and then obviously delivering a baby stretches everything out. In France, you're required to do pre and post-delivery exercises with physical therapy for your bladder. We know, and it's covered by their medical system, we know that if you teach a mother at birth the Kegels and the exercises to do for training the bladder, it prevents somewhat urinary incontinence when you're 90. So the newer concepts now are teaching those women when they're pregnant and postpartum exercises, stretches, how to work with the bladder, how to control the urine. And if you're suddenly 80 and having to deal with this, I'm sorry I'm telling you about prevention, but it is worth talking to your kids or grandkids that are pregnant. Have you talked to your OBGYN about some exercises you can do to help your bladder and parts to prevent incontinence as you get older? So what are these exercises? I have another slide I'll go through about Kegels. I'm sure most of you heard about that, but we're learning a lot more about the bladder is not just this independent organ sitting in your body, not connected to anything else. This is not going to be rocket science, but we're learning if you strengthen the muscles all around your abdomen, if you strengthen the core, all those muscles somehow are connected, both not only the muscles, but neurologically. So we have physical therapists specially trained to work with things such as doing a bridge. Does everyone know what a basic bridge is? You're lying flat on your back knees bent up, and you're supposed to kind of thrust your pelvis a little bit up into what we call a bridge. Those kind of positions, they've actually done studies on. Not only do they help strengthen your core, but they help the whole bladder, urethra, the sphincter, and urine control. So there are some physical therapists, I'm going to work with ours here, hopefully, to start a program. The work on exercises just to help urine incontinence. I'm not going to say it's a magic pill. It is exercise. But just like any other exercise, the more we study it, we go, wow, that really helps. Well, if I can do that instead of taking my pill that causes dry mouth and fuzzy brain, I'll take the exercise. And in a second, I'll show you the slide on Kegels, and we'll talk about that. But I am not going to demonstrate all the exercises here. But needless to say, especially yoga and Pilates, the kind of core all the way around your body exercises seem to really help with the urge incontinence. When you got to go, you got to go. Hormones, the whole latter half of this talk is going to be a little bit about hormones. But I will say that the more I read and the more I studied hormones and incontinence, the more my mind was blown. Some of the treatments, even just topical estrogen, vaginal estrogen, cuts down on 70%, supposedly, of urinary incontinence as you get older. And we'll talk about that in a minute. But if that's something we can do safely versus some of our stronger medications that aren't so safe, why is that not being studied in educational? Why not more educational information on that? Other ways to prevent incontinence: weight. Obviously, the extra weight you carry will push on the bladder and all the parts, male and female. Sometimes helping lose weight, posture, and exercise itself will help with incontinence. Before starting any medicines, I always talk to my patients about caffeine. Obviously, some people are very sensitive to caffeine. One cup coffee or tea, and there goes the bladder control. Just something to think about. Alcohol, same thing. As we get older, sometimes the alcohol can make the incontinence worse. And then sweeteners, supposed to be sweeteners, artificial sweeteners, especially saccharin. Sometimes I would have my patients do studies. What if you take Diet Coke away for a week? Tell me how your incontinence is. So you definitely want to look at caffeine, alcohol, and artificial sweeteners, potentially making your incontinence worse. And then finally, avoid constipation. Any extra pressure on the bladder and those parts can add to incontinence. So keep the stools as regular as you can. Metamucil, someone was talking about earlier. Ding, okay. All right, so what if you've got incontinence? Obviously, we're not talking to women who are pregnant in this audience, most of us. So what if you got it? What do you do? Exercises we talked a little bit about. And again, I'll have a slide on Kegels. Medications. A lot of, especially women, will be on medications for incontinence to help you hold the bladder better. And men have something more, usually to shrink the prostate. To get specific, for an overactive bladder, so you're going too much or you're going and you can't control it, they're trying to a lot of times they'll put you on what we call an antimuscarinic. So it's trying to either stop the bladder spasm. Okay, sometimes the bladder actually spasms and squirts out that urine, or it helps the urethra, the muscle tone down there, hold the urine a little bit better. And again, I apologize to the medical amongst you. We have the side effects of those of these pills, tends to be dry mouth, sometimes some mental brain fog, falls, constipation. They're not our favorite in geriatrics, and yet that's what we got. So and again, this is for overactive bladders, more in women. Our newer medications tend to have some fewer side effects, but any of them are not easy to take as you get older. But we have pills. So we have pills to help you. You want to talk to your doctor. Men, it's a little different. Some men will have what we just talked about, spasm or problems with urethra. More commonly, we have problems with the prostate. And I'm not going to talk about the prostate today. That is a whole nother talk. And I will say that the urologists are great with prostate because most of them are men and most of them will definitely talk to you about your prostate. But obviously Tamsulosin, Flomax, we have pills to help men if their incontinence is caused by their prostate. I talked a little bit about topical estrogen. This is a topic that's just near and dear to me. So what I'm talking about is for females, vaginal estrogen. So like those creams or suppositories that some women were given or recommended, 90% of women should probably be on it, and about 3% of women are. It's a topical treatment that helps the thinning of the vaginal walls. But guess what? It doesn't just help the vaginal walls. It's that whole area, as we can imagine, that has receptors. They're also studying something called topical DHEA. We'll talk about that in a minute as well. It's another hormone-like substance. You want to talk to your own doctor. You can't just run out and get these over the counter. It's definitely some of our newer treatment ideas, but it seems to be safer and more effective than the pills we use. Some urologists, female urologists, or treatments for bladder also will use Botox. Sounds crazy, but injections to stop the spasm, right? So the muscles around the bladder and the ureters can spasm, and then you lose control of the urine. So what if we just block the muscle spasm? Simple way of thinking about it, but it's Botox, and they'll do injections every couple months that just stop that spasm. You have to go to Charlotte or Winston for some of these specialists, but that's another strategy. And finally, there's all sorts of surgeries. 30, 40 years ago in my office, we had lots of women that would go what we called a bladder sling. Big surgery where they tuck up the bladder, sew it up. Not done quite as often. It just wasn't quite as successful as we planned. They also now have nerve stimulation. They'll go in and do surgery on the nerves that innervate the bladder. Again, you obviously want to try the things on the top of the list before you get down to surgery. So backing up a little bit, I keep bringing up Kegels. Most women and men probably know what they are, but it's a pelvic floor muscle training, right? The idea is we get older, everything sags. I don't have to tell you all that. Anything from our earlobes all the way, our breasts, knees, everything just kind of droops and sags, and that is just part of aging. So the idea is as the vaginal area, the ureters, all the core muscles, everything kinds of weakens, the idea is to strengthen all that to hold your urine better. Sounds simple, but it's quite amazing data to show that it works. You can do your own Kegels, right? That's when you just squeeze. No one knows you're doing it. You just squeeze internally your own muscles. You can do it through physical therapy departments have it. They even have those machines you've probably seen advertised that you kind of sit on and they stimulate you. I don't remember what they're called. The idea is basically just getting those muscles to work again. Wake up down there, hold the urine. Let's all work together now. Yoga, Pilates, abdominal muscles, I already talked about this. But if you want more information, I would like to see a program a little more aggressive here at the Pines. So hopefully with our physical therapy department, we can work on that. It's quite individualized. You can imagine some people are already doing yoga, and some people may not even be able to get on the ground to do a bridge any longer. So it's very variable, but heck, if we can do exercise and avoid medicines. Okay, so in summary for this section, take home points. You want to talk about it. If you have urinary incontinence, bring it up to one of your doctors. As I said, it's a little tricky on who you bring it up to, your internist, your gynecologist, your urologist. And our one female urologist we had up this way is not here anymore. I think you have to go to Charlotte or to Winston, Wake Forest for a female urologist. Second of all, exercise, physical therapy and core pelvic exercises, definitely you want to read about. Watch out for caffeine, chemicals in your diet, and how much fluid. And then find your specialist. All right, we'll take questions on that in a few minutes. Next section, I want to talk about urinary tract infections. Okay, this is very different. Cystitis, bladder infections, urinary tract infections. We call them UTIs. I won't speak too long on this topic, but it is very important as we get older. We used to think anytime someone got a little confused, they have a UTI. Mom got confused, it's a UTI. Grandma is not doing so well, it must be a UTI. Any woman, especially over 50 or 60, send off their urine, put them on an antibiotic, the end. About 25 years ago, we discovered almost all women over the age of 55 have some bacteria living in our urine. Just the way it is. They just live there, they don't cause trouble. But if you tested everybody here, at least for the women, you'd have some bacteria in your urine. So we were over treating, right? You don't want to just give antibiotics for no reason. So nowadays, for diagnosing a urinary tract infection, if you're over 55, which I think we're all, even me, we're all over 55, in women, you go by symptoms, okay? So just because someone checks a urine, that's not a UTI, a urinary tract infection. Your symptoms are blood you've seen in the urine, painful urination, you go to pee and it really stings. Even things like smells a little different or a little cloudy, we don't use that anymore for diagnosing. That can happen from dehydration, it can happen from vitamins you're taking. Men, it's a little different. Men don't have bladder infections as often. That's great. Usually if a man does have a true bladder UTI, bacteria in the urine, we want to check. We want to send you to a specialist. We want to find out why you had a urinary tract infection, and usually just from a enlarged prostate or some kind of obstruction. Treatments have also changed for bladder infections. We try to use 5 to 7 days of antibiotics at most. We don't recheck your urine, and we try not to put you on antibiotics year round. Some women used to take antibiotics every day to prevent them. We try not to do that anymore. We created resistant bacteria, antibiotic resistance. Take home points. Most women over 60 have bacteria in their urine. Go by symptoms, avoid antibiotics when you can. And I forgot, topical, there's my thing again. Topical estrogen, the estrogen vaginally I talked about. They're also studying that is looked at as potentially up to 60% decrease in urinary tract infections in women as they get older. Now, does that mean everybody runs out and gets vaginal estrogen now, especially as we get older? We don't know yet. But if you've had trouble with recurring urinary tract infections as a woman, you definitely want to talk to someone about maybe using estrogen vaginally. And certainly younger women around menopause and beyond may want to think about a topical estrogen. All right, next 10 minutes are going to be on hormones, and then we can open it up for questions. Good? Okay. So hormones. It may seem strange I was talking about urinary incontinence and now going to hormones, but I've already tried to connect this. They actually all are connected. The main hormones I'm going to touch on: estrogen, progesterone, testosterone, and yes, women have it too, and DHEA. And why do we call it DHEA? Because no one wants to say dehydroepiandrosterone. I can't even say it, which is an adrenal steroid precursor. So basically it's a hormone in your body that helps create testosterone and estrogen. All right, so let's start with estrogen. Now I know, again, most of y'all are way past menopause, but it's an interesting topic to me. And it's interesting to know what we're going to do with this as we do get older into our 70s, 80s, and 90s. Taking you back to 2002, there was a very large study called the Women's Health Initiative. And you all may be familiar with it because basically the original results of this, it was looking at hormone replacement for women when they were going through menopause. They started this study and they said, oh, we got to stop it early. Everyone's getting breast cancer, dying from heart attacks. And they said, that's it. All women come off hormones. So I know y'all, some of you were in that age, and I was first in practice where we suddenly ripped everyone off their estrogen and progesterone. You can't take that anymore. Sorry for you. Meaning as a, when you're going through menopause, if you were having symptoms, if you were having hot sweats, if you were having dry skin, we took all the women off the hormones. We said, it's too dangerous. We cut them off cold turkey. And women, I remember running into my office so upset. I don't feel good. My hair's falling out. I don't feel good. I have no energy. I'm not sleeping. I'm angry all the time. vaginal dryness, sex hurts. I mean, the list went on and on and on. And we said, tough luck. I'm sorry. You can't have your estrogen back. I mean, it's really a bummer. So years go by and they kept looking at this data and they said, whoops, sorry about that, guys. Actually, estrogen, as long as it's taken with progesterone within 10 years of menopause, actually may be very beneficial to you all. Sorry about that. So it's complicated, very. You definitely, as I always say, want to talk to your own doctor. And this is probably now more for our daughters and granddaughters. But it is such an interesting story in history and still playing out because doctors are still a little bit scared. Well, I can't give you estrogen. I think there was a study. No, you got to go back and read up. You got to keep up on the data. It depends on person to person. We're all different, obviously. But in many women, the benefits of hormone replacement therapy outweigh the risks, especially for urinary tract infections and vaginal dryness, UTI, and urinary incontinence down the road. So first of all, I'm sorry from the medical profession. If we had left many women on hormones, at least that 10 years around menopause, it seems to be that helps prevent incontinence as they get older. It prevents bone loss, osteoporosis. It prevents dyspareunia, painful sex. It actually reduces the risk of heart disease, can lower the risk of dementia, and lowers your cholesterol. Now, there's a lot of caveats to that. This is not a menopause lecture. It seems to be you need to start those hormones within 10 years of menopause. So menopause is when your period's been gone for sorry for all the men out there, probably boring y'all. Menopause is when your periods end for a full year, you're in menopause. If you're going to use estrogen and progesterone, estrogen replacement therapy, you want to use that within 10 years of that menopause time period. If you start it after those 10 years, you can potentially then increase your risk for heart disease. So again, say you're 80 and you said, you know what, I saw this lecture from Dr. Stowe. I have some of these symptoms. I want to talk to my doctor. It's tricky when you get 10 years beyond menopause, which most of y'all probably are. That doesn't mean it's illegal. It doesn't mean you can't have hormones. And some of y'all are probably on hormones, but you just have to be a little careful, more careful after 10 years after menopause. Does that make sense? There are risks, blood clots and strokes. It's mixed data. So if a woman comes in 65 and has a history of blood clots, obesity, and heart attacks at a young age, estrogen is maybe not the best. If a woman's at higher risk for osteoporosis and dementia, we may recommend the hormones. So final line there is do not stop or start your hormones, but it is a topic that's very interesting to me over the past number of years. So the take-home point on that is, again, we need to talk more about menopause. We have menopause specialists now, y'all probably know. We have a menopause society. We have doctors that deal specifically with menopause. We have female urologists that are charging to DC to say, why have we not had a female representation? So first of all, talk about it. And the take-home point, sorry about taking everybody off their hormone. It is what it is. Now we know more. Estrogen, progesterone, and testosterone can continue to be taken. A lot of times I get asked how long you should take them. Again, it's person to person, but we try not to stop them too early. And finally, if you have symptoms or want to talk about it, find a doctor or caregiver that knows something about this and cares. Sexual health as we age. Again, this is a whole topic that's probably don't have enough data out there and we need it. In fact, when I was trying to write up some of these slides, I remember Dr. Ruth. Do y'all remember Dr. Ruth from like the 70s and 80s? Like she was so out there, right? We're like, that crazy doctor. And years later, we're like, how come we don't have more doctors like that? In general, as we age, I think we all know libido, which is the drive, the sex drive, the wanting a desire for sex, naturally goes down a little bit. Your function obviously goes down a little bit, meaning everything from erection to, vaginal dryness is the function slowly, steadily gets worse. That's part of aging. Some we accept, but things like painful intercourse, we have ways to help with that. So it's important to know what's normal as you get older and what maybe we should be able to help you with or to talk to your doctor about. And then, of course, psychological. I mean, so much as we get older, the stress of it, if you have, for instance, urinary incontinence, the thought of having sex or sexual intercourse may be not attractive to you or your partner. So that's when counseling, when psychological issues can also come to play. It's obviously not as easy as when we were teenagers. When someone wants to talk about sex, loss of desire, or loss of function, as we'll call it, both for men and women, first thing I like to do is what I always like to do: what can we help with? What can we look at that may be causing the problem here? So don't forget to look at medications. All right, we know codeine and Percocets can cause sexual problems, and this took us years to figure out, especially 40, 50, 60-year-olds that were on Percocet for their back suddenly couldn't have an erection or lost their drive for sex. Get them off their narcotics. Wow, the drive is back. They can maintain an erection more. Of course, again, you don't just stop your pills willy-nilly, but you want to look and make sure none of your medicines are causing these side effects. SSRIs are the antidepressants, the Paxils, Lexapros. There's serotonin reuptake inhibitors. They can cut down people's drive for sex. We are a little bit concerned in that in the youth, but we don't have to worry about that here. But they definitely have a side effect sexually. And then your blood pressure pills, right? And again, do not stop your blood pressure pills. But some of them are known to have more sexual side effects, especially either erection problems or sexual drive. Thiazides, so the diuretics, and the beta blockers are known. Don't stop those. But if you're having problems, it's worth talking to your doctor. Can any of my pills be making this worse? Can we look at maybe an alternative here? Or do you think I may not need this pill? All right. I think I got 5 minutes for testosterone. Testosterone, another really interesting topic. So testosterone, I learned nothing about in medical school, nothing about in residency, except that it was for men, but don't give it to men because it'll cause prostate cancer. Next. Fast forward now, men know we use it, or at least talk about it for men, and we even check levels. But it's not just for men, okay? Women have testosterone in much smaller amounts, but it is part of our body. And just like estrogen and progesterone go down during menopause, so does testosterone. For some women, that's fine, and for some men, that's fine. But for many women and men, as the testosterone drops, it has a lot of side effects. It can cause, when you have low testosterone, it can cause loss of libido, right? Sex drive, bone density, right? So osteoporosis, muscle mass, red blood cell production, UTIs, mood, hair, skin, it goes on and on and on. One of my favorite, if anyone's interested in this topic, you can Google, Dr. Rachel Rubin is like my most recent idol. She's a female urologist up in Washington, D.C. area. She has a lot of podcasts, and you can look her up in the news. You can read some of her studies, but she's charging ahead with this testosterone replacement in women. And I find that interesting because years ago, I used to dabble a little bit in testosterone replacement in women. A woman came in, losing her muscle mass, hair was thinning. She'd been yanked off her hormones, her estrogen. Well, what about the testosterone? Now, women's levels are very different than men. So if men had, in those days, we had a packet of testosterone gel that men would apply to the skin daily to replace. The packet was each day. For women, I would say use a pea-size amount, so that packet should last you 1 to 2 weeks. It was amazing. Many women that had symptoms would come back a month or two later. I feel amazing. I feel myself again. I feel like I can think clear. My muscle strength is better. Their blood work, a little bit of anemia would go away. Their depression would start to get better. Somebody's got to study this stuff. Little by little, it's coming out. So first of all, women, do not use testosterone if you have prostate issues. Okay, so, right? Like, why haven't we studied this? Whoa, uh-oh. Did I touch something? Anything? Anyone good at I don't know what that just did. There we go. All right. I don't know why it hasn't been studied. It's a long story. There's still a black box warning on testosterone, which people are finally protesting in DC. Doctors are too. Can we look into this a little bit more? It comes in injections, patches, creams, gels, pills. We do not have a good way to measure levels in women. And I'm certainly not telling everyone out there to go run and get testosterone. But it's an interesting topic. It is starting to be looked at as a potential replacement along with estrogen and progesterone. So keep your ears open. Take home point, talk about it as far as sexual health. So loss of desire, obviously men, all right, I'll be blunt. Why? I will tell the story. It's gonna embarrass me, but Rachel Rubin is the female urologist I mentioned. And she was giving a talk at one of our internal medicine or AMA meetings. She said men would go in an office and doctor, it's terrible. So I don't know, 70-year-old male goes into a doctor's office. It's terrible. My erection is just a little bit weaker. And the doctor says, oh my God, this is terrible. The good news is we have a pill, Viagra, or we have a prescription. We have help for you. It's covered by your insurance. There you go. A woman comes in and says, doctor, it's terrible. You know, I don't have an interest in sex. My hair is thinning. My skin is dry. Sex hurts. You gave my husband Viagra. Now he wants sex. I have urinary incontinence. My periods have stopped. I don't even know what to do. I'm sorry, honey, that's menopause. It's okay. On you go. And I heard Dr. Rubin tell that story and I thought about it and I thought, wow, I'm interested in that. So that's originally how, this was about 5-6 years ago now, how I got interested in looking into some of this data a little bit more. So talk about it. Watch for medication side effects. If there's vaginal dryness or pain, again, for women only, there is help. And finally, psychological. Some of the counselors are really good out there for sex and difficulty with sex as you get older. This is a shout out to my sorority sisters from Dartmouth who have put up with me for the past 10 years on this journey as they keep poking at me. Come on, Michelle, tell us up-to-date information on hormones and sex as we get older and what to expect. So that's my Kappa Kappa Gamma class of Dartmouth 88. All right, so before we move on to questions, we have a good 15 minutes for questions, 15, 20. I'd been asked at the beginning for what to know with Dr. Stowe. These were the topics I kind of originally came up with that maybe would be helpful to y'all here at the Pines. Just sharing what I know or what I hope I know. We did an introduction to geriatrics. We did brain health. Now we've done urinary incontinence and hormones. Next talk can be potentially on Parkinson's and movement disorders. So again, this is what's coming up. But if you all have topics you really are interested in or want to delve deeper, I know nutrition has been a hot topic. This is what we're hoping to come up with over the next year. All right. So now I'm happy to open it up to questions, and I'm told we have 2 Vanna Whites, and so thank you guys. There's microphones in the back.
Would you speak a little bit about nocturia and why it gets worse in old age and what we can do about it?
Yes, the question was, can I speak to nocturia and what can we do is in old age and what we can do about it? So nocturia technically means knock is night and uria is urination. So going to the bathroom, peeing, urinating a lot at night. So again, it's not necessarily normal to have nocturia as you get older. Not everybody has to go more at night. And there's 2 different kinds of nocturia, right? There's the kind where you just wake up because you didn't sleep well, something hurts, or there was a noise, or you're a light sleeper, which that does happen as we get older. And then you realize you have to go to the bathroom versus the having to go to the bathroom wakes you up. So first of all, you got to decide what's actually happening. If it really is nocturia, you're going more often at night. In men, you want to specifically ask your doctor about nocturia, urinating at night, and a lot of times it's the prostate getting bigger. That just happens with age in most men. Again, I'm going to defer to the urologist because that's a whole talk, but we have pills to shrink the prostate. You obviously want to get your prostate checked to make sure there's nothing no cancer or anything terrible going on there. For women, it's a little different. That was a lot about what we talked about today. Sometimes it could be as simple as not drinking, try not to drink much fluid after 7 p.m. or whatever time you want to pick close to the bedtime. Caffeine, as we talked about, you don't want that cup of coffee anymore at night. You probably want to cut that out. Alcohol, you may want to cut back on that if you want a good night's sleep. What am I missing? Nocturia. And then medicines. Make sure some of your medicines, if they're actually causing a diuretic, is a good example. Some of us are on Lasix, furosemide, or a medicine to get the fluid off. Most of us try to prescribe that to you in the morning, so you're not up all night urinating. So kind of what I went through in this lecture, same thing with nocturia. Look at your medicines, look what you can do day to day, and then ask your doctor about it, because it's very variable, male, female. Does that sort of answer your question? What else? Sure.
I just have one comment. As the Botox has gotten more popular, there are people in our area doing that, urologists. So if you are interested in that, there's a lot of feedback on this, call a urologist and ask them. But I do know there are a number of urologists in our area that do that now.
Good. That comment, really good, Dr. Lockridge. The Botox for urinary incontinence is done now locally in our area. You can talk to your urologist. There may be some gynecologists doing it too, I'm not sure, but it's definitely worth asking about. The only thing with the Botox has to be, it's not a permanent treatment, but in some people it works very well. Who would have thunk it? Botox. No wrinkles, exactly. What other questions or comments? Maybe I answered them all. All right. Well, that's it. That topic is probably not as, it's interesting. I think the topic on brain health, especially when we went into the nutrition piece, seemed to be very popular. So we may want to expand on nutrition topics in the future. Any other topics y'all want covered or ideas that you have? Yes, sir. Good suggestion, Dr. Skin health, benign to malignant. And maybe we could even get a dermatologist or two to come in and give us some tips. Might be good. I like it. Other topics you'd like covered? Brain fog. She said brain fog. Yes, that goes with the brain health. And when I get the answer to that, I will present it. No, I'm just kidding. Brain fog. I like it. That could possibly go under, we had a lot of questions on nutrition, brain fog, and inflammation. We may want to delve deeper into that topic. I'll have to write that one down. Anything else?
Right here, Dr.
How about UTIs? Does cranberry help or not?
I forgot to put that in there. Cranberry. The question was whether cranberry helps with the UTIs. There's very mixed data. The information on cranberry, what it does is change the pH to prevent urinary tract infections. So it may be helpful to prevent them. You can't, it doesn't really work. If you have one, you don't want to use that to treat it. Once in a while, I get a call from somebody, I tried cranberry, it's not going away. Once you have a UTI, you kind of need it right? You need the antibiotics. But as far as prevention, it seems some of the studies look pretty good. The caveat is don't drink a ton of cranberry juice. It has a lot of sugar in it. So the studies really were with like a quarter cup at most. So you can use just a little bit of cranberry juice, dilute it with water, or they even have cranberry capsules now. Yeah, the capsules, because people would start, drinking a couple of cranberry juice cups and then, their sugar would skyrocket, and that doesn't help anything. But the cranberry juice itself, especially if it's not with all sorts of preservatives, looks pretty promising. So if I have someone who has recurrent UTIs, I do recommend cranberry. Anything else? Oh, good. Thank you. I was going to say thank you all. Thank you. Thank you.
We've opened up both the doors in the back for you guys, so go ahead and head on out whenever you feel you need to leave. Thank you.